physiology and the applied and the clinical.
Thank you, Dr. Bharti. Quite elaborate and newer aspect of the EOG also. Thank you very much. Our last speaker is Dr. Nidhi. So she'll be talking about the VEP. The ERG part of the VEP, the VEP part of the ERG is most looked for. People say whatever, if any ERG, okay, the VEP. So in VP, we can find VP in so many places, especially all the neurologists that do VEP very regularly. So she'll be talking about the VEP in a little elaborate way to make us understand. Please go ahead, Dr. Nidhi.
Good morning, everyone. Thank you, sir, for accepting me in your IC. I would be talking about visual evoked potentials. I have no financial interest. Now, electrical signals are generated at the visual cortex in response to visual stimulation. These occipital responses correspond to the central visual field, and they assess the intracranial visual pathways and their functional integrity, ranging right from the retina to the optic nerves to the optic chiasma, optic radiations, and the occipital cortex. The peripheral retinal projections are within the calcarine fissure, but the central retinal projections are in the occipital lobe. The foveal projection is magnified at the cortex. So the linear extent of the cortex in millimeter is very high, corresponding to the fovea. It is 5.6 millimeter per degree, and 10 degrees away from the fovea, it is only 1.5 millimeter per degree. So the indications for which VP can be used is optic neuritis, multiple sclerosis, optic atrophy, hereditary optic neuropathies, toxic neuropathies, traumatic brain injury, compressive optic neuropathies, glaucoma, amblyopia, and also for unexplained visual loss, malingering, pre-surgical evaluation, and measuring the visual acuity in non-responsive subjects. So the requirements here, we will have an active reference and ground electrode. The impedance should be less than 5 kilo ohms, and between the active and the reference electrode, the impedance difference should be less than 20% always. Now the placement of the electrodes follows the 2010 rule, in which the whole head is divided into multiple divisions, and we have the reference electrode, which is placed at FZ position. We have the ground electrode placed at the top of the head, and the active electrode placed at the OZ position. So this is how the machine will look once we connect the electrodes, and here we need to check that all electrodes have the impedance of less than 5 kilo ohms. Now the stimulus used for VEP can be a flash, pattern, color, or motion. For the flash VEP, the Gansfield stimulator is used, and for pattern VEP, we have the CRT monitor. Now, this is all according to the ICF standards. If we look at pattern VEP, that is the most commonly done VEP, done in patients who have good visual acuity. Patient should be light adapted, sitting at 1 meter with correction and undilated, and it should be done monoocularly. Flash VEP is done for patients who have poor visual acuity. Here also the patient would be light adapted. The room will be dimly illuminated and done monoocularly. In pattern VEP, we have a checkerboard pattern in which the pattern is reversed. We have different check sizes and a constant luminance and high contrast. In flash VEP, we need the field size to be more than 20 degrees and at least one flash per second, that is a frequency of 1 hertz, and a low intensity and high flash intensity and background intensity. In pattern onset and offset VEP, the stimulus is similar to the pattern VEP, but here the pattern is flashed on and then off. So pattern VEP most commonly used, investigation of optic neuropathy. Additionally, flash would be used when the optics are poor, cooperation is poor, or vision is poor, or when pattern reversal cannot be done. Pattern onset and offset is done in cases having nystagmus or malingering or amblyopia. So in pattern VEP, this is the checkerboard stimulus. The pattern is reversed, black to white and white to black. Here we need to avoid the artifacts like blinking of eye. The lesser the better. The total number of tests that are done per individual test should be at least 64, and this test is repeated at least twice. In cases of infants or uncooperative patients, the numbers per test can be reduced. So checks which are subtending in 15 minutes of arc are the best stimulus for testing foveal vision, and 60 minutes are superior in evaluating parafoveal function. Therefore, using more than one check size will increase the diagnostic yield. If the resulting VP using the 60-minute check is poorly performed, then retest using a larger check size or use a pattern onset stimulus. So this is how the waveform will look for pattern VP. We have a negative, positive wave. So the first negative is N75. Here the most important one is the first positive, which is the P100. The latency needs to be seen here. That ranges from 90 to 110 milliseconds, but then it can also vary from lab to lab. On an average, 100 is taken as normal, and the P100 amplitude should normally be more than 5 microvolts. So this is how the output will look. Criteria for abnormality, the latency criteria is prolongation of more than 3 standard deviation, or interocular latency of P100 is more than 10 milliseconds. In cases of amplitude, we need to see that interocular amplitude ratio is not more than 2:1. If the amplitude is abnormally low or high, and absence of identifiable VP from the midline and lateral occipital sites. So this is how a normal waveform will look for the right eye and the left eye. In cases of traumatic optic neuropathy, here you would see that the right eye is normal and the left eye has the neuropathy, and there is a delayed implicit time as well as the reduced amplitude versus the right eye. In cases of AION, here again the implicit time might be normal, but the amplitude is reduced and the waveform would appear a little wider. Papillitis, again delayed implicit time and moderately reduced amplitude in the right eye versus the left eye. This is a case of patient having optic atrophy with left eye having no PL. The left eye, no signal is elicited versus the right eye, which was normal. So VEP can also be used to evaluate the prognosis and the progression of cases having optic nerve gliomas and neurofibromatosis. So over the time, if you see that the P100 latency might actually increase, and thus there is compression due to the optic nerve glioma. This is a case having ethambutol toxicity, and the P100 shows less peak times. This is a case of patient having meningeal tuberculosis where there was again prolonged P100. Coming to pattern onset and offset VP, pattern is flashed on and then off. So 200 milliseconds it is on, followed by 400 milliseconds of off equiluminant diffuse background. The check site again is 60 minutes for large and 15 minutes for smaller. Pattern onset or pattern flash stimuli produces a more robust VP than does pattern reversal in the central 30 degrees. So this is the difference. In case of pattern onset and offset, we have it on, and then for twice the amount, it is a diffuse equiluminant background. And in pattern reversal, the white-black checks are reversed. So pattern reversal stimuli usually exacerbate nystagmus and interfere with the ability of the eye to maintain foveal fixation. Thus, detection of visual acuity is good with this in cases of nystagmus. It is also less sensitive to poor fixation, eye movement and deliberate defocusing. Thus, it is useful in examining patients that might be malingering, and it has the most productive stimulus for monitoring amblyopia. So this is the waveform here. The C2 is most important, whose latency is normally 100 to 120 milliseconds. Flash VP, again for uncooperative, unconscious patients having media opacities, to prognosticate eyes with poor vision before planning surgery, and to monitor visual function of babies. So VP is often prognostic in delaying maturation of the visual system. So usually the infant with delayed maturation has a normal flash VP, but permanently cortical blind infants will have abnormal VP. So this is how the waveform and output will look. Here we can adjust the peak and troughs of the waveform to get more prominent waves. So here also we have multiple negative and positive waves. The most important here is the P2 and N2. So P2 latency is normally 100 to 120 milliseconds, and the N2 P2 amplitude normally should be more than 10 microvolt. So this is how the output will look. What we need to see majorly is the N2 P2 and the P2. Just a note on sweep VEP done for infants, suspected malingers or disabled subjects. Here the visual acuity is actually extrapolated and calculated in logmar units. So this is how the result interface will look, and everything is extrapolated here through an algorithm. Multifocal VEP is a little more advanced. It is an objective assessment of visual field like a perimetry, more commonly done for chiasmal and retrochiasmal dysfunction, glaucoma, and in chiasmal misrouting, especially in albinism. These are all the waves that need to be seen for all the three major types of VEP that are done. That is all for VEP. Thank you for listening.